one of the things that I'm really excited about that we're doing at Tampa General is specifically utilizing our tissue biorepository for research purposes. And one of the things that we're doing there, right now in AML, we primarily are looking at the genetics with targeted based sequencing. And so at Tampa General and, working with different companies, one of the things that we're looking at is broadening that and doing whole exome, whole transcriptome sequencing. So really, not just looking at a set amount of mutations that are in AML or MDS, but looking at all the potential possibilities for mutations. And this will allow us to not only, have mutational features that we know currently, but also to have additional mutations that then we can detect and potentially use for therapeutic reasons in the future. Outside of the tissue biorepository, another thing that I'm, doing is, partnering with the NIH and the NCI. And there what we're doing is we're looking at in MDS how the immune system affects the microenvironment for MDS, and do specific mutations in MDS influence the way the immune system interacts. The other things that we're doing at Tampa General is we're bringing on a couple novel clinical trials. One of them is looking at a really interesting pathway that I think a lot of leukemia doctors are exploring, which is the macrophage checkpoint pathway. And so currently, when you think about immune therapy and how it's being utilized in cancer, primarily we're looking at T-cell based therapy. And what we call checkpoint inhibitors, are primarily focused on T cells. So there's been a big push to look at other immune cells in cancer, and specifically in AML, one of the areas that we've seen that has promise is macrophages. And so what we're actually doing is basically turning off a switch that downregulates macrophages and allow the macrophages to basically eat cancer cells. And so there's a lot of different ways that we're, manipulating the checkpoints that do this. There's, a drug sort of in the late stages now in a phase 3 clinical trial called magrolimab. But magrolimab is just one of the drugs that, targets this pathway with, there are several other drugs that are coming up the pipeline, hoping to potentially improve on side effects or efficacy. And so, one of the trials that we have is a new type of macrophage inhibitor in combination with Vidase and venetoclax, which is a standard therapy for elderly patients in AML, and seeing, are we able to continue to push the boundaries of what we're able to do with macrophages. The other clinical trial that we have at Tampa General that is of interest is looking at BCL2, and similar to what I sort of spoke about with macrophages, BCL2 is another pathway that is being utilized across different cancer types, and that's with venetoclax primarily. There's so in AML, the FDA approved for elderly unfit patients Vidase plus venetoclax, and that has been the backbone now for really all of our elderly unfit patients, but possibly the backbone for potentially all patients with acute leukemia. And so another clinical trial that Tampa General is interested in and participating in is looking at a second generation BCL2 inhibitor and seeing if again we can sort of improve on what we're able to do with venetoclax, be more selective for BCL2, potentially improve efficacy and side effects as well. When it comes to ASCO, I think the things that I'm most excited about are some of the new therapies in MDS. For a very long time, we had only a couple options for patients with myelodysplastic syndrome, especially low-risk patients, transfusion dependence, where we primarily use a red blood cell stimulating agent as our mainstay frontline option. So at ASCO, there's now 2 phase 3 trials with novel agents that are hopefully gonna either add to or potentially improve on what we're able to offer in that low risk space. And so I think a lot of people are excited to see what those phase 3 results look like today. And hopefully that will lead to FDA approvals that will improve the care for patients overall. You have, you know, red blood cell stimulating agents, erythropoietin agents, Aranesp, and Procrit. But ultimately, once you get past that point, we basically have immune modulatory agents like lenalidomide that, really work well in certain subsets of MDS, but not as well in other subsets. And luspatercept is one of the drugs that, a lot of people are really excited about. Currently, it has an approval, in patients that don't respond to ESAs in the frontline setting, and is approved specifically for a subset of patients that have an SF3B1 mutation or ring sideroblasts. But the big question, and I think the big exciting theme here is, can we start to use luspatercept in all of our patients? Is it potentially better than what we're doing with standard of care ESAs? And because the nice thing is luspatercept is really well tolerated, pretty minimal side effects, and overall, I think a really good drug that patients, seem to benefit from. And so if we can start to push the boundaries, because you got to think about being an MDS patient, especially a low risk MDS patient, their biggest, decrease in quality of life is just this continued going to the doctor, getting transfusions, even if in the best offices, you're still going to spend, 4 to 6 hours every time you're getting a blood transfusion. If you're having to do that, once a week, twice a week, it's a lot of, lost time. And if we're able to get better drugs like potentially luspatercept moving forward, I think it's really going to improve the quality of life for a lot of patients.